Welcome to the Health Workforce Technical Assistance Center's webinar series. This webinar is entitled Understanding How the Diffusion of Physicians Affects Areas of Underservice, and it was presented by Tom Ricketts on March 30th, 2016. And at this point in time, I will turn the event over to our presenter, Tom.
Hello, I'm Tom Ricketts. I'm here today to talk about how the diffusion of physicians affects areas under service. I'll explain a little bit about diffusion physicians and define underservice as we go along. So I'm glad that you're all here to talk about or to listen to me talk about this today. Let's move right on ahead. Really, I'm approaching this from the notion of the movement of physicians into specific places, and those are places that are designated as underserved. So my central hypothesis of this is that we can anticipate diffusion based upon the characteristics of the places to which physicians go to and the places from which physicians leave, as well as the characteristics of the physicians to understand whether we can more easily direct or structure policies to help fill underserved locations, primary care, health professional shortage areas specifically. So if we combine the places and people with the best programs, we can then optimize our recruitment and retention in underserved areas. Now, I'm going to focus on rural underserved areas. Of course, there are urban underserved areas. I'm also going to focus on primary care. There are areas of shortage for general surgery, psychiatry, other specialties. But I'm going to deal with really the heart of the problem for small, rural, and perhaps inner city and some other places. That is getting primary care practitioners in place to take care of the needs of the populations of those places. Now, the policies and programs that I'm talking about really focus on recruitment and retention as the two general processes that we get people out into underserved places. So recruitment is the thing that gets them out there, and I'll spend a little more time dealing with the recruitment, but we're talking about recruitment of people who are predisposed to some degree to going into rural primary care. There is evidence that people with a rural background are more likely to go to rural places, and those with some familiarity with problems of underserved populations are more likely to go into rural underserved places. We also recruit by a focused content in the programs where we train folks, so that there are special programs and trainings tracks that focus on rural populations or on underserved populations, both in medical school and in graduate medical education. But then we also have recruitment via really giving people fiscal incentives, loan repayment, scholarships, incentive payments, and potential support of their practice in the form of real payments or in some sort of capital support. Retention is a little bit less of an issue in what we're talking about, because that keeps them there, and I'm talking about people who are moved into there. But really, there are two important ways that we try and retain physicians, and they have some effect on the let's say, trajectory of physicians into rural and underserved places, and those are bonus payments or practice support. And practice support is fairly wide-ranging thing, and I'll talk a little bit about that. I have to hit this. There we go. Now, there are a lot of programs, a lot of federal programs that deal with the recruitment and retention of practitioners. This is a graphic that tries to show the complexity of these programs, where we're talking about getting a physician who, from the day they're born all the way to the time they're retired, targeting them for practice in a rural or an underserved place. So when we talk about AHECs covering the whole lifespan, I mean, we are talking about recruitment and orientation programs to health sciences, and even involving people who are going to be the potential parents of practitioners, because one of the most predictive factors about whether somebody's going to become a doctor or a nurse or a dentist is whether their parents are doctors or nurses or dentists. But we're talking about a number of programs that focus either across the life course of the practitioner or in specific places, and these are multiple programs. If we look at the programs and how they overlap, this takes specific programs that are in HRSA and talks about how they overlap with one another. This gives you an idea that we have a system that has many, many different programs, many, many different initiatives, not all of which really communicate very well with other programs and projects. So we have something of a patchwork, but we have a patchwork that covers really the whole life course of a practitioner's career. And in some sense, these are brought together under the umbrella of HRSA, but some of them are not in HRSA. Some of them are, especially at the state level, and some of the bonus payments are actually come out from other directions and other, let's say, legislation that creates these. So we've got in one sense, coordinated in that they're generally housed together, but in another sense, uncoordinated system of policies and programs that attempt to move people into underserved places. I think we need to pay probably a little more attention to the degree to which these programs are coordinated, and probably it would do better if we did communicate a little better under some form of an umbrella, but that's a legislative problem, because a lot of these programs are authorized under separate jurisdictions and separate legislation, although they have generally been brought together or were brought together to some degree under the Affordable Care Act. Now, these programs, Bob Conrad, a colleague of mine, categorized these types of programs into three types with the three M's. He calls them mercenary, military, or missionary, and they really give you a sense of what the heart of these are, whereas the mercenary programs, people do it for the money. Military is they do it because they've signed up and they're told to go, or missionary is they go into an underserved place because they believe it's the right thing to do. All of these things can happen simultaneously to an individual, but sometimes it is important to see that one or the other dominates in a decision-making process for a practitioner or for a program to bring in a person. Give you a little more idea of how you divide these military, missionary, and mercenary programs. Is the National Service Corps and state loan repayment programs, to some degree, when you have an obligation or J-1 visa obligations, are really those things that obligate an individual, and they're told where to go, fundamentally. Whereas the normative programs, where people who are really responding to a missionary vision of what they would like to do, really are those people who seek out a program that supports their interests. And they can do this through some of the old HCOP programs or rural industry team training, which are things that are no longer there, but really attracted people in to get specific training. But there are individual institutional programs that train that. Geriatric training, for example, tends to attract people who really have a notion that they want to do good for a population, and that some of these are tracked into underserved areas. But the mercenary elements are something we spend a lot of effort on, and there is a good deal of funding that goes into bonus payments. Now, I put J-1 and visa incentives, in this case for employers, because there are programs that where employers, that is, employer of a practitioner, can cooperate with that program for them to understand or for them to realize the benefits of bringing in a practitioner, which may be more considered a little bit on the mercenary side because they're trying to fill holes and keep their practice afloat. Okay, that's the background of what I've been talking about. We've got a lot of programs that are out there to move people into rural underserved places. And we've sought to find out what is the best way to target individuals and to match people up with the place that they would thrive in and stay in. And so I was really trying to understand if by looking at data that describe the movement of practitioners from one place to another in the United States, in this case primary care physicians, whether we could really build a predictive formula in which we might be able to develop policy in which we could influence the general flow of practitioners into rural underserved areas. So I took a lot of data. In this case, I'm sorry for the typo there, but it was concatenated files of the AMA from 2006 to 2013. Now, we've been working with these files since 1981 and done some prior work that described the movement of physicians. But in this case, we're trying to look at more recent data because the things that happened in the 80s are very different from what happened in the early part of the 21st century, given some changes in programs and changes in the content of the physician pool, that is the new practitioners coming in and both the demographics as well as the expectations. We did also include HWTAC files where we're looking at them at the zip code level, at the county level. We were also looking at the county characteristics or the general characteristics of HWTACs using the area health resources file, but some other, as we say, kitchen sink data sources, which are demographic and commercially available data sets that give you a look at what the community is like and that can be used in some analysis. This also used GIS analysis and analytic techniques to look at adjacency and distance of moves. We really didn't end up doing a lot with adjacency, but we did examine distance a little bit and found that that was not really important, but a little bit more about that. We had some zip imputed files that we did include information about Medicare payments and payment levels to see if that was something that either attracted or repelled practitioners if you paid high rates for Medicare or if you paid low rates for Medicare, and the degree to which there was Medicare penetration, that is the portion of the population that was supported by Medicare, because the bonus payments are through the Medicare program, and so that was an important thing. Initially, we tried to use the PICSA files. PICSA files developed by the Dartmouth folks with the support of HRSA are really at the level that would be appropriate to primary care, but they've developed 2 iterations, and they're a little bit awkward to use in that they're hard to, let's say, compare over time. But I believe that if we were to do this kind of work and be as effective as we wanted to, and I think probably at a pixel level analysis would be necessary. But let's go with what we have here. Now, I'd like to comment on the concatenated files, because this is something that we put a lot of effort into and is, in one sense, very difficult to do, but after we've gotten, let's say, good at it, it's possible to make these things so that they're useful for analytics. And the one thing about the AMA master file is that it does have a unique ID for each individual practitioner. And for all the things that people say about the master file, that it might not be as accurate as it should be, it is a continuously updated, individual-based record that I think is really actually underused for longitudinal analysis. And I applaud and appreciate the efforts of the AMA in doing this. It is done on a commercial basis on their part, but they do release it for research purposes, and I think that it is possible for folks to really make better use of this, especially its longitudinal aspects. Of course, the data are updated annually. That means that the file is updated, not necessarily each individual practitioner. but perhaps 30% of the records are updated annually. Now, if it's 30, 30, and 30, it might be that 10% might not find an update in 10 years. And so there are problems with lags as people disappear from the file because they do know when they come onto the file, when they go into a residency program or when they come in on a visa, and in some cases on a license. But when the practitioner does move without some update into one of the feeder data sets, the file may not reflect that. So there's some lag in the data, but in general, when looking at this over time, you do get a good sense of where doctors are and have been and where they've gone in the recent past. Now, this is the summary findings on movement overall. And in the 2 years, 2006 to 2013, we have looked at 620,390 active physicians, that is, that they're listed as active in the file, and we excluded federal physicians who included federal employment. We excluded residents, although we examined them separately for their movement for other reasons. And we also excluded anybody who was over the age of 80 years old, 80 or over. That's an arbitrary number. It doesn't necessarily mean that everybody retires at that time, but we did, and I would say that the people between 70 and 80 are perhaps problematic in this, but that's not that many. But in that group in 2006 and 2013, that is, they were in both files, 185,207 moved to a different county in that 7-year period. That is, they didn't just move across town. Now, if across town crosses a county boundary, that counts in there. But we looked at those people who moved to another jurisdiction at the county level. We had done this before tracking 2006 and 2011, and we found 25.5% had moved in that 5-year period. So it makes sense that over 7 years you'll have a higher proportion of people who move. Now, if you look at forever, whether over the course of a lifetime, doctors do move, but really you're going to find that proportion would increase up to 7, perhaps 10 years, and then people generally stay stable, or at least they move only once every 10 years, perhaps, after some initial early moves in their lives. Now, that's a longitudinal study that will be, well, if I can find, if anybody wants to send me a graduate student, I'll be happy for them to work on that with starting with the 81 data. But when we looked at this initial diffusion, we explained to people who thought that docs stayed in places for a long period of time after initial movements from, say, residency, and then perhaps another move for a, let's say, to change their practice environment. We recognize that the physician, we need to recognize the physician supply is really dynamic, and that we find that consistently we're about 30% of practitioners move in that time period, and in any given year, about 20% of all docs are going to move. And this is, remember, in this is not the residents, the people who are resident in the first year. We're talking about the, let's say, the free-range doctor supply. So policies really should recognize the dynamic nature of the supply. If we are going to look at programs that recruit and retain practitioners, because if you're looking for a 100% retention rate or a 70 or even a 60 or a 50% retention rate, you're well above the normal motion of practitioners. And so I think that all of the programs that we're involved with or support at the federal or state level have to recognize that there's a background of movement that you want to influence rather than necessarily stimulate a move. You really want to redirect a move and take advantage of people, the fact that people are going to move anyway. So we also looked at the fact of whether people in this diffusion, the earlier work, we found that people, as they age, they move to better opportunities, reflected by the demographics of the place they go to. We also found some other interesting things, is that people specialize and then re-specialize, that they change their specialty. And when they change their specialty, that's often indicative of a move. And when I say change their specialty, they might go from general surgeon to a subspecialty within general surgery, or medicine to a subspecialty, and then they go back to a generalized, a more general focus of their practice, and that might, that's less predictive of a move, but it might be something that also causes them to move, or is a response to their movement. So when we take the 2006-2011 data and compare, we found that the movement in 2006-2013, this is a crosstab of that movement. So we found that 36.4% of all doctors active in both series moved. And so you see there's again, there's a fairly large flux of practitioners. So we wanted to give a sense of who were these movers. And if we look at this is a portion of the regression to see whether, okay, do primary care doctors move more or less? Primary care doctors move less. Surgeons move less. It turns out that it is medical specialists and other physicians who move more. DOs move more than MDs, net of other things. And of course, the older you get, the less likely you are to move by a fairly large factor. And interestingly enough, females move more than males. Just a big summary of this is primary care moves less, surgeons move less, osteopaths move more, older people move less, and females move more. So in the gross notions of who's moving at any given time, you have these characteristics as background. They're relatively consistent over the years, but it also gives you an idea that if you're talking about recruiting somebody, you don't necessarily want to recruit an older person if they're not less likely to move, if it means moving into another place. If it's primary care, that seems counterintuitive to the notion of that's who the people we need to redistribute. So you've got this kind of background notion that is a little bit resistant to some of the, let's say, thinking in policies and programs. So the things that we're wanting to know is, would it be good to know from these data that we have who among those went into a HPSA and went out of a HPSA? And then what kinds of places lose or gain docs, that is in general. And then can we develop some sense of the probability that a place X gets position Y based upon the characteristics of place X and position Y? Can we develop a prediction formula in order to really target individuals? And then is there something about the place that really is, as I write this out, is conditional upon these probabilities? In other words, can we predict where a place is likely to lose and become seriously underserved? So given this kind of notion of analytic, given this analytic approach to the data, the question is, can we come up with something that's useful to build a policy on? So in the several years that I've worked on this, I've come up with the notion that there are three clusters of things that really affect whether people go into or leave an underserved area, and those I call them person, program, or place. Just for it just makes for a nice little PPP notion that fits into the recruitment, the R&R of recruitment and retention. And we hypothesize that the person effects are really early in the process, and the program effects are over time, and the place effects are really something that have more to do with the retention over time. But this is just a kind of a general schematic to see how how these things might fit together and to see where we would apply any policy related to focusing on person, program, or place. Now, a lot of people have been working at this for a long time, and I think it's important that we reflect and remember that some of the best work that was done on this was early in the development of manpower research, and when a number of very, let's say, strong economists were working in this area, and they left a really good set of guidance and really demonstrated how we could analyze data to predict the mobility of physicians and how diffusion in the underserved areas could be understood. The Ernst and Yet, the third one item down, is an entire book that is quite useful still to this day. And these other studies are useful for folks to really understand what we know, because I see a lot of people reproducing work that has been done. It's useful now when we have a change in things like, say, nurse practitioners or PAs, but fascinatingly, a lot of this initial work was done with nurse practitioners and PAs or physicians in the context of nurse practitioners and PAs. There's more of this. Really an important group that worked on this was the folks at Harvard. Joe Newhouse did work on this early in his career and was revisited by Meredith Rosenthal and Alan Zaslawski, and that was a study they called Diffusion or Distribution of Physicians Revisited. Again, here's some citations to earlier work that we had done, but I want people to understand that this is not a new field. There's a lot of work that one has to review before jumping into this, and I want to give full credit to these folks who dealt with this. Now, when we're talking about diffusion, there's a clear, let's say, imbalance in the numbers of physicians by their geography, and you can see the places where they gang up in the Northeast and the places where there are not many in the mountain Midwest. You know, that's almost a physics of diffusion, is that people are going to go into places where there is less competition, and the economic argument about that has to be recognized. Now, what we did was this, but this is at the state level. We actually did county to county, 3,080 counties by 3,080 counties, but this is the kind of matrix that is the background to the type of analysis, and then we tried to understand what the characteristics of people who move from a place like somewhere in New York to a place like somewhere in Wyoming, and could we understand who is more likely to go from New York to Wyoming or in reverse. So the net loss of gain versus gain in total MDs, now this is just the number of docs who left and who were in both files 2006 to 2011. You can see that there is a net loss out of the Northeast, the heartland of the Northeast, the Mid-Atlantic, and the Midwest, and out West, where there are a lot of people, and to the South, where there are a lot of people, and there are let's say, economic drivers that move people into those places. Now, that's like a lot of people moving at any given time. And if you're talking about migration, the background migration of populations is as important to physicians as it is to an entire population. This is a map that comes from the New York Times. It is quite interesting. You can click up your state and find out where people came from to go into your state, and in this case it happens to be North Carolina where I live, and you can see that for those people who in 1990 and 1900 everybody was born in North Carolina, but recently we have a lot of people coming from other places. So physicians do this as well. They follow the migration trends of the entire population. In this background situation, although it's not directly controlled for in the regressions that we did, is something you have to recognize. So that an analysis in 1990 might yield results, at least volume certainly, but maybe the specific results will be different from what you find in the 2015. Now here's a picture of that county-to-county motion or change. This is for primary care, and this is in ratios. So the ratio gives you a sense of both where the population leaves as well as the practitioners. And in places where the population is going down, which is in the central states along the 100th meridian, you can find that there are an equal number of practitioners leaving, but there are some places where they're gaining in this central part of the United States. You can see this in the green, and the brown is where people leave from. And you can see that there are brown throughout the United States. Hardly any place other than California is immune from this type of, let's say, drain of practitioners from counties into other counties. But there are the number of counties that are gaining in primary care population ratio are actually far fewer than those that are losing, and they're somewhat concentrated in certain areas in the west, southwest, and surprisingly not in those counties in California. But you can see some places in Virginia and North Carolina that, interestingly, are gaining in ratio. Again, here's another look at the county-level change, primary care physicians, just a different map thing. So what we did in the analysis was we focused on those people who moved from rural health professional shortage areas to urban places, that is net loss, and those people who move to rural, in this case whole county HPSs, from urban counties. So the idea was to find out, okay, who are these people who were going into the good places, or the places that are desirable that they move into, rural whole county HPSs, and those people who are leaving them. And you can see that 1,386 in this 2006-2013, that we had 1,386 who moved into and 1,960 who moved out of. I'm not going to make a lot out of the net loss because there are people who were not in both years. That is, there are people who were, say, from licensed or became who were not, you know, who live a little bit older or whatever. They're not in this 2-year sampling that moved into those places. So this doesn't necessarily mean that there's a net loss to rural HPSs. But what this does is give you a sense of who the people are in those 2-year windows that moved into or away from rural underserved areas. The counties in the analysis are here. The rural whole county HPSs are the pink shaded. I hope that's coming up on your screen. It's pink shaded. And this is contrasted to the whole county non-HPSs. There are far more rural whole county HPSs in the United States than non-HPSs. But this is the areas that we focus on, those people who move into and out of these places. And they're spread across the United States, but not necessarily in some areas, but you can find them in the upper Midwest and Intermountain states and like that, and in the southeastern and let's say the southern parts of the United States. So the idea was to take and find out those people who moved into those places or moved away from those places, and we used a number of variables that looked at the people. Now, we wanted to look and see whether they attended a public medical school versus a private medical school. There are some research that talks about that as being a predictive factor. We looked at their age. We did include whether they were a resident in the 2006 in one set of regressions and not in another. We looked at their gender. We looked at their the origin of their medical school, whether they were a medical graduate that was interacted with U.S. public medical school. We looked at whether they were an osteopath. We also looked at characteristics and variables that describe the place in the program, in the place of the county. What was the per beneficiary Medicare payment? That varies widely, we know from the Dartmouth research. We looked also at a standard Medicare payment, standardized Medicare payment for the county. We looked at the number of critical access hospitals, whether that was a factor, as that's a a programmatic thing, but also a resource thing. We looked at the FQHCs in the county, the National Health Service Corps sites in the county. We looked at infant mortality rate as a proxy for health, per capita income, which could also be said to be a proxy unemployment rate, 2012. We also looked at the county area. This stood in for those very large places out west. We looked at the population of primary care, that is to see if there's the competition was a factor. We also looked at the change in the primary care to population ratio, that is very recent change, 2010 to 2012, to see how much dynamics or whether there's dynamism in the population there. And then we looked at the population that had no health insurance as another place variable in our regression. So what did it all come out with? Essentially using those predictors to look at whether somebody would go into or go out. And I'm going to review the results in a very broad, let's say, graphic way. The specific results are available on a policy brief that is available on the website of the North Carolina Workforce Research Center. I'm sorry, that website is not going to come up on a slide, but I think it would be pretty easy to find that if you just look for the Workforce Center. You can send me an email and I'll happily send you the policy brief. So here are the results for factors affecting recruitment and retention in underserved communities, the negative side. This is when it comes to people moving into a place, moving into the right place, that is moving from an urban to a rural underserved. These are the things that are associated with their not moving, with their less likely to influence their move. That is, and interestingly enough, we found that the National Health Service Corps presence and the FQHC presence were associated with lower rates of movement into communities. Now, that might be a good thing in that the NHSC and FQHC might reflect a steadier physician practice profile in that area. So, however, getting new people in was not associated with the presence of NHSC programs or FQHC. We found that females were, in this case, less likely to go into these rural underserved areas, or they were more likely to go out of those rural underserved areas. So this is net of the bad things that would happen, both go into a place and then go out of a place. So a female was less likely. U.S. graduates versus IMGs. IMGs more likely to go into a rural underserved place and less likely to leave. Now, we found that Medicare dollars, low density, per capita income, and more doctors locally were also negative factors, that is net negative, that is less likely for practitioners to go into places with high Medicare dollars, in this case, low density, higher per capita income, and more doctors. So net of all these things, it's not necessarily a coherent picture. Now, what about the positive sides? For those things that promoted whether people go into rural underserved or stay in rural underserved. And if they're a resident in training, and this was an earlier answer, did this include resident in training? We did separate regressions, including residents, and then we had one without residents, or we had a series without residents. So resident in training is really something that is a positive indicator. So you would recruit from younger people who, if they're a resident in training in their earlier year, they are more likely to go into the place. And since this is only a brief period, they're also more likely to retain if they're a resident in the earlier year. But also the things that brought people in were high infant mortality rate. It was a higher perception of that might be perceived by the individual as a more needy place. That was correlated with, and to some degree, but keeping that as clean as we could, the high percentage without health insurance. But then a high positive primary care ratio in the community. Also, that was interesting in that seemed to contradict some of the other results. But a critical access hospital in the county was also associated with a better chance of bringing people in and a better chance of keeping them there. But also people who came from public medical schools were more likely to go. And then interestingly enough, the older docs were more likely to go into these underserved places, although they were less likely in general to migrate at any time or diffuse to another place. So older docs might be targeted for underserved places. There'd also be people who you can retain easier, but this is against their general trend of moving less. So the power prediction in this is 18 to 25% in the various regressions. Now, these were highly significant regressions, but with a lot of variables in them. The question is whether you can take this information and say, let's build a policy around this. Let's target only older male docs who are international medical graduates to really focus the kind of work that we want to do to bring people into underserved areas. So would you want to invest in a program that is based upon this type of regression analysis when it brings only 25% predictability? Well, the 25% predictability, in this case, that's your R-squares, is pretty high for a large number of research of this type of large N research. So that's the end of the presentation. We're in a situation where we've produced a policy brief around this, had some conversation with HRSA, and we're opening the conversation with you all with this presentation. The analysis is what I'd describe it as advanced numerology that can be refined, and it needs to be examined, peer-reviewed to really get a sense of whether we're doing the best we can with the data. And in that spirit, we're opening up to folks to say, okay, well, what can you learn out of this? Do you want to take a crack at this type of analysis? And generally, we're more than willing to let people join us. So overall, I'd say that in the policy brief, my conclusion was, well, you can't really develop a rock-solid predictive model, but you can get some pretty good hints from the data. So that's the presentation of data. For those people who are like I said, a little more geeky and want to look at the regression structures individually, I refer you to the policy brief. And then if you're really, really invested in this, I can certainly send you the code. Happy to take questions now.
Okay, thank you, Tom. At this time, we'll go ahead and start the Q&A session, as you mentioned. Once more, to those of you in the audience, you may ask questions using the chat panel on your screen, and please make sure you direct your questions to all panelists. First question, does the location of physician refer to practice site or residence?
This is practice site as best as we can predict. In the AMA file, we have an algorithm. I mean, there is a practice location and a residence location in the files. Then there's also what we call max. We maximize the probability that this is their practice site based upon an algorithm that is actually developed by the AMA. We've had a lot of, we do a lot of, let's say, verification, or have in the past, a lot of verification of this, and it's pretty good on practice site. I wouldn't, especially at the county level, I wouldn't be so worried about it. If I was trying to locate the individual practitioner based upon their, even their practice site data, especially in this day and age of very large group practices that have a single practice address, but they actually function at some distance, I'm beginning to be a little bit less certain of that right now.
Next question. What could HRSA do with these analyses? What existing policies should they evaluate, or what new policies could they consider?
Well, I talked at the beginning about the very large range of programs that they have that are not necessarily coordinated. I have advocated within HRSA and outside of HRSA for a good deal more coordination of effort. I believe that there are sometimes some of the programs that are working at odds, and I know that at a very at a specific local level that some of the programs don't necessarily pay attention to the others. Although in general, in most states, there is good coordination. So my first message is recognize what all the things that you have that would influence somebody to go into an underserved area, and then coordinate them. Now, whether it can be that this is going to build a priority list for the type of person you recruit into a place, such as there is a priority list for HPSAs, there's a score that is given to HPSAs, a severity score. Would you have a probability score placed upon an applicant based upon this information? I don't recommend that now. I would, if I had a predictive power in the above 50% or 60%, I think I would say yes. But right now, I would say that really there's not much at the individual level that you can do. I would like to break this down to individual programs to say whether a person went through a federal program in the data, but that's not available to these data sets right now. We have done some work in the past on National Service Corps, but even that now is getting very hard to assign to an individual practitioner or a unit of analysis. Next question.
All right, thank you, Tom. Do you have any sense of how successful the Rural Track training residency programs are in terms of retaining physicians to stay and practice in rural areas?
Yeah, they're doing pretty good. Separately from this, we did a look at Rural Track training programs and the degree to which they're successful, and they are quite successful. I think that's, you know, one of the things that says you can do this. The unfortunate thing about them is everybody, I think, is I think appropriately applauds these. They are very, very small in relationship to the total number of people who move into rural underserved areas. So I don't have the numbers right in front of me, but in that same period, the number of people who went into rural training track programs is far less than the total number of people who actually moved into a rural underserved area. So it's a small and important but marginal influence to the overall movement of physicians. And that's part of what I've been trying to say is that you have a lot of flux. You have people moving in and out of these places, and the portion who are affected by an individual program is actually quite small when you take the individual program. But the portion I'd very much like to know, and I don't know, the proportion who are touched by any program, be it AHEC, be it loan repayment, be it rural training track, be it whether their father was a general surgeon in rural Montana. So in and of itself, it is effective. Combined with other things, it moves the big needle only a little bit. Next question.
Okay. How much do you think an urban bias of the data set affects your results? Some providers have both urban and rural practices.
Well, I don't know what urban bias means. And you say some providers have both urban and rural practices. I have the ability to look very closely at a longitudinal data set that looks at people with multiple practice locations, up to 3 separate ones. And I know the proportion of people who have multiple practice locations. Very few have something that spans an urban and rural practice in the totality of all the practitioners that they look at. In this case, it's about 25,000 doctors in the state of North Carolina. in a breathtakingly small number, have 3 different locations. However, when you take the denominator of particular rural places, it becomes larger. But I don't think that this is this is not enough to move the needle or affect the analysis too much. Now, I say that feeling confident, but if we could run the data and make it, and I could disprove my hypothesis, I'd be happy to. But I don't have the data right now to do that at a national level.
Okay, Tom. Next question. This one's from us, actually. Our New York resident exit survey finds that practice decisions made by newly trained physicians relate in part to proximity to family. Do you think this is a contributing factor to the broader physician migration patterns?
Well, yes. I also, not to be rude, but exit surveys need a little bit more confirmation to check their validity. Do people move based on family? Yes. I mean, we've spent a lot of time, or I've spent time interviewing people as to why they're in a place, both primary care practitioners, specialists, especially surgeons. And I find that people who make moves both to get to family and get away from family. I think that the moving for family reason has to recognize that there's a negative aspect to this as well. And in a little cohort of surgeons that we looked at, half of them moved to follow a spouse and half of them moved to get away from a spouse because they were part of a divorce. And that is those people who move for family reasons. So yes, it's a factor. I'm not sure, it's one of those things I'd love to have in there. And there is the potential to look at physician dyads, pairs, who are moving together. Now, that influence might be an interesting fact, is that they sub-optimize. In other words, they go to the place where 2 people can get a job. And I think many people out there would know that that situation exists and it influences people to some degree. Question is, how many of those people are there? And I think there's more now. Data says that there are more now. But I really don't know, other than saying there's more, whether that's a 20% of the population or 2% of the population. So family's important, but I think the specification of where this would send them to is harder to find out than saying, yeah, I'm going to do it because of a spouse, ailing grandparent, or an angry spouse.
Okay, thanks, Tom. We have one more question for you. Say I'm a PCO. What are some of the practical applications of your work, and how can I find more information about it?
Well, as a PCO, I think the whole idea of, you have to recognize that people are moving around a lot more than I think people realize. Even when I confront a PCO in North Carolina and they're talking about, oh, the people have been there all their lives, and you go and show them, no, really you've got a fluid population of practitioners. I think people have to, cope with that and understand they need to be either understand that process of change and movement, that the biggest problem facing local practices is how to integrate and assimilate new people and how to let people go graciously in a way that doesn't hurt the practice, so that they spend as much time on, let's say, flux as they do on fixity. So that's one lesson. Now, the practical aspects of that are, I think, recognized by PCOs in rural offices who know that they're always dealing with the dynamics of it. And but their job is probably to either reduce the dynamics of exit by a margin, 10% perhaps, and increase the dynamics of entrance by a margin of, say, 10%, as opposed to come up with everybody's going to stay for long-term retention of 7 to 10 years. So, I mean, just understanding your context is good, and that for those people who feel, who recognize that individually might know that it also confronts other people. Now, the second part of your question, where can you find more results about this? Well, as I said, going to the website for this Rural Research Center, the North Carolina Rural Research Center, I'm on a different computer, and I'm not easily able to squirt this out to you, but by reaching out to the North Carolina Health Workforce Research Center, you'll find we have I think an 8-page policy brief with a bunch of R-square and Greek letters in it that might give you a sense of more. But I think also looking back in the history of this and the things that people are doing so that you feel like you recognize that there's been a lot of work might be helpful as well.
Okay, thank you, Tom. And just to let you know, we can go ahead and post a link to that brief on our TA website as well, so people will be sure to find it. With that said, I guess we'll go ahead and end the event for the day. Tom, thank you for joining us. We very much appreciate having you on. And thank you out there for attending our webinar. Just to let you know, we will be posting our slides shortly to our website. So if you want to download them, check back very quickly at healthworkforceta.org. We hope to see you again in the future. Thank you, and have a good day.